have Dr. Sandip Saha. Dr. Sandip Saha is the Chief of Interventional Pulmonology at Buffalo General Hospital, United States of America.
Namaskar, Sat Sri Akal, and Adab. My name is Dr. Sandip Saha, and it's a great privilege to be with all of you here today. Just waiting for my presentation to come up. I'm an interventional pulmonologist, and this is a relatively new field, and I appreciate all of you that stayed behind because I know the food is here and whatnot. But we'll make this nice, sweet, and informative. So I can just talk a little bit about myself, and while he's loading up. So I'm Canadian, but my parents are from Kolkata. This is my first time being here in Delhi, so I really, I'm enjoying this, being here in the capital. Did my training at, there we go. Hey, there we go. All right. There we go. So did my training in St. Martin, which is in the Caribbean. I was on the Dutch island, and then ended up doing internal medicine residency at Wayne State University, which is in Detroit, Michigan. Did then pulmonology and then critical care medicine, so 2 additional fellowships at Michigan State. And then I was very curious about interventional pulmonology, and I ended up at Yale University. The reason why I mentioned Yale, only because I had the honor of learning under the chief of thoracic surgery over there, Dr. Frank Detterbeck, whomever is treating lung cancer knows who created the lung cancer staging guidelines and basically the TNM staging guidelines. So after fellowship, this was in the middle of COVID, I was asked by Buffalo General Hospital and the University of Buffalo to be their first interventional pulmonologist. So this is, so that last picture is Niagara Falls, so I'm basically 15 minutes away. It's not frozen like that as it is right now, but that's how cold it gets. So what is interventional pulmonology? Well, it's a combination of a variety of disciplines of medicine. So from ENT, otolaryngology, to thoracic surgery, oncology, and radiology, all combined. And we provide minimally invasive endoscopic and percutaneous procedures in order to diagnose and treat neoplastic and non-neoplastic diseases of the airway, the lung parenchyma, and then also of the pleural space. So in terms of IP as a field, it's been around for a very long time, but not formalized. And so when I say a very long time, you have, documentation in the pyramids of people performing tracheostomies. You have mention within the Rig Veda itself about tracheostomies. Hippocrates even mentions how to treat infections of the pleural space. But our first formal IP program didn't take place until 1996 in North America, and that was in Leahy, Massachusetts. But the first fellowship only started in 2010, and that's where I graduated in 2019. So I was the 9th fellow of Yale. And so there's only a handful of other international sites where they train interventional pulmonologists, Japan, France, and Italy being the other ones. Right now, North America is blessed with 42 programs, but if you look at the rest of the world, there's less than 20. And this in itself provides a very huge imbalance into how we treat and diagnose our lung cancer patients. And so I'm a part of the World Association of Bronchology and Interventional Pulmonologists, and they created the first inaugural Interventional Pulmonology Fellowship, which is in Istanbul, Turkey, and the inaugural fellows just started in 2023. And so basically, one physician from India, her name is Dr. Dua from, I think, Uttarakhand. She graduated from there last year, and then there's another Indian physician joining this year from Hyderabad. And so there's 2 physicians. The whole purpose of this international fellowship is to have them come for about 3 months, learn in a very dedicated environment, and then come back to their home nations to sort of train and teach other physicians. So, lung cancer statistics, this is the big one. So from the WHO, we know that lung cancer is the leading cause of deaths worldwide, and smoking is the leading cause of that with approximately 85% of all cases. But most of the time, when do those patients arrive to us? usually stage 3, stage 4. And the whole opportunity here is to perform a screening process. And so we want to screen those high-risk individuals. In the United States, we use something that's been combined with the USPSTF, which is the Preventative Services Task Force, and the CDC to sort of perform low-dose CAT scans. Those are on individuals between age 50 to 80. They have had a 20-pack or a more year history of smoking, who are active smokers, or who have quit within the past 15 years. And so using the American College of Radiology lung RADS criteria, if we pick up a nodule that's less than 30 millimeters, then we use this scoring system. Sorry, my mouth is dry. And so we want to basically perform a follow-up for those that are lung RADS 3, 4, and up. Sorry. And so if we have any incidental nodules that are caught outside of the screening, we use a Fleschner's criteria to sort of help us further sample those nodules. And so we have a variety of nodules. Not all lung nodules are solid. We have subsolid, partially solid, ground glass opacities. And so that's what we have to figure out. How do we best sample these? So when we talk about IP and lung cancer from a diagnostic perspective, we perform bronchoscopies. That's what everyone thinks a pulmonologist does, but we do a little bit more than that as an IP physician. So in order to diagnose those primary lung nodules or lung masses, we perform flexible bronchoscopies or robotic navigation bronchoscopies. But the bread and butter is basically this right here, which is staging of the mediastinal lymph nodes. And this is via an endobronchial ultrasound. And so this is the scope right down here, and you can see the tip. I can use the mouse, but so right down here, this is the ultrasound probe, and then we attach that. So when we go down into the trachea, we touch the wall of the trachea with that ultrasound probe, turn on the ultrasound setting, and then we can see the variety of those stations right there. I can sample any of those except for the 8, 9, and then the 5 and the 6. But basically, we have 5 major lymph node stations. Knowing who's sampling those lymph node stations is very paramount to anyone who's going for treatment. Because if you have inadequate sampling, incomplete sampling, then you don't have a proper stage. And if you don't have a proper stage, this basically changes how you're going to be managing those patients. So in addition to the robotic bronchoscopy, I also perform cryobiopsies of peripheral targets where through the actual catheter probe, we can freeze a portion and then remove with the whole catheter a larger chunk. Therefore, we're preserving the architecture for our pathology colleagues. Performing thoracentesis of malignant effusions and also pleuroscopy of exudative pleural effusions of unknown etiology. So moving on to the robotic systems. I use this system right here, which is the Monarch. This is basically created by Johnson & Johnson. There's a variety of systems, but don't just think you have a robot, you can start driving inside the lung without any adjunct therapies. And so what are those adjuncts? So this is right over here, I included this CAT scan, and right here is the lung nodule that was sent to me. It was in an 82-year-old female who was asymptomatic, but had a 8 millimeter nodule. This nodule, as you can see, close to the aorta. It's not peripheral. So in the United States, in Canada, when people start doing these lung cancer screenings, the majority of the physicians getting back the report read the report, but they don't look at the imaging. And so this is where not reviewing the imaging, and if you send someone off for a CT-guided biopsy, you're potentially going through a lot of normal parenchyma. What's the risk for the CT-guided biopsy? Pneumothorax, bleeding. These are the things that you have to sort of keep in mind before you send someone off. So this is a patient that I reviewed. I found a bronchus sign, which is an airway leading me to the target, and I was able to use the navigation system. So when we ask, okay, who is a good candidate for a CT-guided biopsy versus a navigation bronchoscopy, I usually measure from the pleural surface to about 2 centimeters, going all around. And if there's a nice window, then that would be an adequate approach, depending on what pieces of technology that you have. But then comes the question about staging. So I perform both biopsies at the same time. One of the primary site and then the other mediastinal staging. So then that way I'm reducing the number of procedures for the patient. So in terms of the adjuncts that I had mentioned, we use, how do I confirm that the needle is in target? Whenever you use a robotic platform, you get a CT scan, and then there's something called CT body to divergence. That means if the protocol wasn't taken appropriately, or the patient was mid-breath, then when you're using the navigation software, the target may not be in the spot that you think of. So we have to use other pieces of equipment right here. And so this catheter right here is called a radial EBUS. So through the robotic channel, I insert this long, thin catheter. This catheter spins in 360 degrees. When I send it out into the airway or into the parenchyma of the lung, I'll either get two patterns. One is a concentric pattern, which tells me the lesion, the tool is directly inside the lesion. The other one is right here, an eccentric pattern. Basically, it's an irregularly shaped pattern. It tells me you're adjacent to the target. So then, what I use is this next piece of technology right here, which is called a Cyospin. So in certain institutions, they might have a cone beam CT. So depending on what brand, what version that you have, my platform is made by Siemens. It's a mobile C-arm, which basically fits over the patient, does another mobile CT scan, and it tells us whether or not the tool is directly in the lesion. The third thing that I use, and we should all be using whenever you take a biopsy, you need to know that you have adequate specimen. So we use what's called rapid on-site evaluation. That helps us assess adequacy. And so this is something that I didn't invent ROSE, but what I did create was something called telecytology in conjunction with navigation bronchoscopy. During COVID, we didn't have enough cytopathologists at Buffalo General Hospital or even the city of Buffalo. So what we did was we purchased a very expensive webcam, this Leica webcam right here, and so that sat on the back of this microscope. As I would sample the specimens from the target, I had a cytotech, and then the cytotech would stream the sample right here, and I could see it live while I'm operating on the patient. And these images was being streamed through a WebEx platform, so something free. It went across the city, and then the cytopathologists in their lab could then tell us yes or no, adequate sample or not. And so this is just basically something that allowed me to receive this award as the young investigator from our World Association of Interventional Pulmonologists. So when we talk about palliative approaches, I perform what's called rigid bronchoscopies. And so a rigid bronchoscopy is a steel rod which goes down inside the airway. And this is where we have tracheal tumors. Anyone who comes with massive bleeding or whatnot, you have to do tumor debulking. The tip right here of the scope is very sharp, so you can core it out, but you have to be very, very careful because right here is the posterior membrane. Behind that is the esophagus. You don't want to puncture and perforate. The other things that we do are, I can control bleeding with something called argon plasma coagulation. This is where we use argon gas to ignite and sort of burn off and cauterize tumors and lesions within the airway. Right here, we can also, through this rigid scope, we can deploy stents. This right here is by one of my colleagues, Dr. Niral Patel at UCSD. They have a contract with one of the 3D printed stents companies in California, and so they're able to deploy these. But, so these are some of the things with the rigid scope. The last thing that we sort of have in the States through insurances is if someone is coming in with malignant, recurrent, symptomatic effusions, I'm able to place tunneled pleural catheters. And so by doing so, I have my team of visiting nurses that go out into the community, drain the patients 3 times a week, and then sort of report back to me. Let's say someone needs chemical pleurodesis. We can do that with either talc, talcum baby talc powder, or even with doxycycline through the catheter and sort of allow chemical adhesion with the actual pleura, visceral and parietal, to sort of come together. If someone develops complicated effusions because they're bleeding or there's tumor progression, then I'm able to place lytic therapy like TPA through the actual catheter and help dissolve the membranes to allow adequate control of the symptoms. So, in conclusion, Interventional pulmonologists, as a field, it's a very new field. The EBIS scope that I had mentioned only came out in 2005. So most pulmonologists that trained never had the opportunity. My attendings didn't, and that's why I chose to go after another fellowship, so I could be complete and know how to sort of stage adequately and get tissue sampling for the patients. But we are really utilized best in a multidisciplinary approach. I sit on a tumor board with other radiation oncologists, thoracic surgeons, and oncologists, and so we all sort of come together to sort of help discuss what would be the best way to sort of approach a biopsy. Physicians in the community at different hospitals usually have my number because they want to ask me, and they sort of ask me to review imaging up front. Because they want to save the patient from either general anesthesia. All the procedures that I do is with GA. I don't do any moderate sedation because when you're trying to insert a needle right next to the aorta or a pulmonary trunk, you can't have them under moderate. You can do it in safe hands, but most patients wouldn't like to do that. So I'm trying to always minimize the number of procedures that I try to do. Knowing your staging and upstaging and knowing which site to sort of biopsy first, doing your physical exams. If you have a palpable supraclavicular node, you can save a bronchoscopy on that patient because if you sample that with local, you're already upstaged them to N3 disease. So you can kind of bypass a lot of that stuff. Doing the thoracentesis up front, you can do molecular marker testing, and that's the whole purpose of this. I try to obtain appropriate and sufficient tissue so that we can do next-gen sequencing. You have so many of these sponsors right here. You can't start doing, all this tissue testing without the tissue. And so knowing who's doing your sampling, who you can trust is really big within your community. And so this is the most important thing. We're in a field where there's always new pieces of technology. So whomever is purchasing these things, just because I have a robot, doesn't mean that's enough. Not everyone has, an abundance of budget. So you always have to know what pieces of equipment that you have, know how to get very good with it, and know the limitations, because unless you know all these things, then you can't really help your patients. So thank you for your time. This is just a picture of in my bronch suite. So this is that C-arm that I was talking about coming in at the head of the patient, and we do that spin. This is the robotic arms, which I use a Xbox controller to sort of drive down inside the lungs. And then right up here is the screen that sort of projects the 3D image of the actual lungs and pathway. So thank you so much. I appreciate your time.